Lisa, and hello everyone. Pleasure being with you all today, and we're going to discuss a somewhat difficult subject, that being tarsal tunnel syndrome. And I'm not sure that the syndrome is as difficult to discuss as is the management of the patient itself. These are very difficult and complicated patient management problems. But I thought it would be interesting to go through our thoughts on tarsal tunnel syndrome and how we're currently managing them from both non-operative and operative points of view. These are my disclosures, and I will talk a little bit about my involvement with amniox a little bit later in the talk. But I think to start things off, first, just in very general terms, we are going to be talking about a nerve entrapment phenomena. And the pathophysiology of nerve entrapments like tarsal tunnel syndrome is one that involves primarily a neuropraxia. A neuropraxia, as you recall, is a focal conduction block. It's basically a nerve in continuity in which there may be a segment of that nerve that shows a conduction block due to a focal myelin damage. Now, most of the time, the damage can be caused by a chronic situation, although acute compression phenomena have been reported. Whether it's by chronic or acute compression, these types do look different histologically based on the amount of focal myelin damage that's occurred. They also act different clinically, with the more acute presentations being more painful than the chronic types. In the very active patient, the athletic patient, we can see both dynamic and static compression that can create these nerve entrapment disorders. They can be associated with a specific activity. They can also be related to patient anatomy, as we'll discuss here in the next few slides. Now, with that background, we're going to specifically discuss tarsal tunnel syndrome. Now, tarsal tunnel syndrome is defined as a compression of the posterior tibial nerve or its terminal branches. And again, those terminal branches can be a variety. It can be the medial plantar nerve, it can be the lateral plantar nerve, or it can even be terminal branches of those two plantar nerve segments. It's important to understand the anatomy of the tarsal tunnel when one is discussing tarsal tunnel syndrome. Just to highlight some of the anatomic points in this area of the posterior medial ankle, we first identified the fibroosseous tunnel. This is the tunnel in which the tibial nerve and the surrounding vascular structures are located. The floor of that fibroosseous tunnel is that of the tibia on the anterior aspect, and then the posterior talus and the calcaneus lateral to these soft tissue structures. The roof of the fibroosseous tarsal tunnel is made up of a flexor retinaculum. The distal portion of that flexor retinaculum is oftentimes alluded to as the laciniate ligament, a ligament that basically extends from the medium malleolus back to the calcaneus and is proximal to the abductor hiatus itself. This flexor retinacular roof extends approximately 10 centimeters proximal to the medium malleolus, and when you're discussing the tarsal tunnel syndrome or a possible release of the tarsal tunnel, you have to take that extended distance into consideration to provide adequate and complete release. When we then discuss the posterior tibial nerve itself, we talk about this nerve that travels down from the posterior aspect of the knee and the calf and then courses to the posterior medial aspect of the ankle. At approximately the level of the medium malleolus, the posterior tibial nerve will divide into medial and lateral plantar nerve branches. Certainly a number of variations can exist in regard to that division. It can certainly be more proximal than the medium malleolus. I've even seen some cases where it's slightly distal to the medium malleolus, but generally speaking, it occurs at that level. Somewhere proximal to the medium malleolus, you will have a calcaneal branch that peels off to the posterior direction. The interesting thing about the calcaneal branch is that it basically passes superficial to the abductor hiatus muscle, whereas the medial and lateral plantar nerves pass inferior to that muscle segment. So again, something you want to look out for when you are performing dissections in this part of the ankle. Now, there are numerous variations of the tarsal tunnel syndrome. Again, the anatomy can be somewhat varied as mentioned. One of the variations one may see is what's called a jogger's foot. A jogger's foot is described primarily in runners, more active individuals. It's considered to be a compression of the medial plantar nerve at the masternode of Henry, so a location distal to the abductor hiatus fascia, and one that some people have related to compression from hypertrophy of the surrounding FHL, FDL tendons or tenosynovitis. The jogger's foot is, it presents different than standard tarsal tunnel syndrome in that there's a localized tenderness or even a Tenel sign that's directly over that more distal location. And in addition, these patients oftentimes will have a specific pattern of dysesthesia or paresthesia with numbness that may extend to the hallux itself. The other variation of tarsal tunnel syndrome to consider is that of distal tarsal tunnel syndrome, which has been described in runners by Don Baxter of Houston, Texas. It's also known as Baxter's nerve syndrome. What it is basically an isolated compression of the lateral plantar nerve between the deep fascia of the abductor and medial fascia of the quadratus plantae. It has been more specifically described as a compression of the first branch of the lateral plantar nerve, that mixed sensory and motor branch that goes to the abductor digiti quinti muscle on the lateral aspect of the hindfoot. One can differentiate a distal tarsal tunnel syndrome, or the so-called Baxter's nerve syndrome, from a plantar fasciitis in that these patients tend to have tenderness to compression over the abductor hallucis muscle itself. So again, more medial than the more plantar pain that's elicited with one that has an isolated plantar fasciitis. This entity was described by Dr. Baxter and Glenn Pfeffer back in 1992. They talked about the possible surgical treatment of this entity with a release of the abductor fascia overlying this isolated nerve, along with a release of the medial plantar fascia. They had an 89% good and excellent results with this surgical release that was specific to this first branch of the lateral plantar nerve, with 83% complete resolution of heel pain. So again, somewhat of a classic article when one discusses tarsal tunnel syndrome as well as the variation of distal tarsal tunnel syndrome or Baxter's nerve. There are many etiologies for one presenting with tarsal tunnel syndrome. There are the extrinsic etiologies that include space-occupying lesions, the most common of which is a ganglion cyst. There are also the possibility of having a neurolemoma in this portion of the tunnel, as well as neurofibroma. You can develop FHL tenosynovitis, which will be an extrinsic cause of compression against the tibial nerve or its associated branches. You can have direct trauma to this area of the tarsal tunnel, or synovitis from the surrounding joint areas. Varicosities have also been described as an extrinsic cause for tarsal tunnel syndrome, as well as tarsal coalition and obesity. There are intrinsic etiologies to tarsal tunnel syndrome as well, probably the most common being diabetes with its neuropathic pain pattern. Rheumatoid arthritic patients can also develop tarsal tunnel syndrome, as can individuals suffering post-trauma sequela. There are also dynamic etiologies for developing tarsal tunnel syndrome, primarily that of flat foot. A flat foot deformity with its associated pronation and valgus at the hindfoot or ankle level can place a stretch across the tibial nerve and its distal branches, creating a tarsal tunnel type syndrome. It's also been described in patients with varus heel malalignment as well as from shoe compression. There are iatrogenic causes for tarsal tunnel syndrome, the most common of which is a calcaneal osteotomy. So it's the so-called surgically induced iatrogenic tarsal tunnel syndrome. This has been nicely outlined in publications out of Vancouver by Krause and his associates. They discussed the incidence of tarsal tunnel syndrome occurring secondary to lateralizing calcaneal osteotomies. I'll refer you to a very recent publication in Foot and Ankle International by those from Brown University, of which Bruce was the lead author. And in the laboratory setting, they found that lateral displacement calcaneal osteotomies and not medial calcaneal displacement osteotomies created this tension or the creation of a tarsal tunnel syndrome. The lateral calcaneal osteotomies were certainly implicated if there was a more anterior placed osteotomy. What they found is as you shift the calcaneus laterally, you're actually decreasing the volume of the tarsal tunnel, thus placing compression on the tibial nerve. So again, an outstanding paper looking at the iatrogenic induced tarsal tunnel syndrome from lateralizing calcaneal osteotomies. And lastly is the idiopathic etiology, and certainly the most common presentation for tarsal tunnel syndrome in the patients that you may be seeing in your office setting. Really no reason why certain people develop tarsal tunnel syndrome. When these instances, you need to look for also a proximal nerve issue, a radiculopathy that may be arising from the lumbosacral-spine region. If you have a radiculopathy from a proximal etiology in addition to tarsal tunnel syndrome, we call that a double crush phenomena. Some of those patients may also have neuropathy on top of those entrapment, and that is then a triple crush presentation, which are obviously very, very difficult to manage. Patients present with tarsal tunnel syndrome in a variety of ways. For the most part, they present with intermittent dysesthesia, paresthesia, or anesthesia to the plantar aspect of the foot. As you see in Netter's drawing there on the right, that the medial plantar nerve extends along the plantar aspect of the foot to the medial 3.5 toes, whereas the lateral plantar nerve extends more along the plantar lateral aspect of the sole of the foot out to the 4th and 5th toes. Tarsal tunnel usually has a very insidious onset, and again, the description of the patient's symptoms can be quite vague and diffuse. There's oftentimes a nighttime pain component to tarsal tunnel syndrome, a so-called afterburn that a patient notices when they first get off their feet in the early evening hours and have that moment of rest after being up on their feet all day. Patients have also described a retrograde or proximal migration type of a pain scenario, the so-called Vallot phenomena, where the pain may extend more proximally up the calf itself. One may describe tenderness over the tarsal tunnel or its terminal branches, and the pain that these patients appreciate is not typically relieved immediately with rest. It will take several hours for much of this pain to diminish. The physical exam is obviously very important to the diagnosis of tarsal tunnel syndrome. A physician needs to know the anatomy to make this diagnosis. A Tinel sign may be present in about 50% of the patients that present with tarsal tunnel syndrome. That Tinel's is basically a percussion test over the flexor retinaculum and the abductor hallucis muscle posterior to the medial malleolar region. You may also elicit some discomfort from just a manual compression to the tarsal tunnel region posterior to the medial malleolus. It's important on these patients that you check their hind foot alignment in stance. Again, a number of these patients may present with valgus arising at the ankle or hind foot level. If they have a significant amount of valgus, particularly on a more acute basis, that can actually put tension on the tibial nerve and its terminal branches. You also have to check these patients for their sensory distribution. It certainly can be abnormal in the distribution of both the medial and lateral plantar nerves. The presence of true atrophy of any of the foot muscles is quite an uncommon finding, and one that you will not be expected to elicit. I believe the physical exam is probably the most important diagnostic test, the most insensitive one. It is important, though, to go ahead and obtain regular x-rays of both the foot and ankle when you're evaluating a patient with tarsal tunnel syndrome. You may identify an individual with a medial base exostosis that may be placing extrinsic pressure on the contents of the tarsal tunnel. You may identify malalignments, such as the valgus malalignment just discussed at the hind foot or ankle level. Obvious arthritic changes, osteophyte formation should also be considered, as should tarsal coalition. The talocalcaneal tarsal coalition can oftentimes present with a very large amount of redundant medial bone, thus reducing the volume of the tarsal canal and thus placing compression on the contents of that tarsal tunnel. An MRI is a useful test if you're working up a patient with tarsal tunnel syndrome. Primarily, it's one that we use to determine if there's a space-occupying lesion, such as a ganglion cyst or neurolemoma. You can also use the MRI to assess local tissues, the joint status, whether or not there may be a subtle coalition or underlying degenerative joint changes. So I believe that, again, mandatory for the work with tarsal tunnel syndrome is not only the history and physical exam, but radiographs and an MRI. Another diagnostic test that you should consider is the dorsiflexion eversion sign. This is described in JBJS in 2001 by Kinoshita and his associates. The maneuver is one, as you'll see there in the photo up on the right. It's an ankle placed in maximum dorsiflexion and eversion with the toes hyperextended at the MP joint level. And you hold that position for about 5 to 10 seconds. And as you do so, that patient may begin to describe a burning sensation through the posterior medial region of the ankle. Basically what this maneuver does is it compresses the tibial nerve as it runs under the flexor retinaculum at the level of the medium malleolus. I believe that if you can elicit pain with this maneuver, you're certainly helping to confirm the diagnosis of tarsal tunnel syndrome, but the absence of pain does not necessarily preclude it. The other test you might want to consider in workup of a tarsal tunnel syndrome, particularly in a more vague presentation, is that of a nerve conduction study along with an EMG analysis. This will typically be done by our neurology colleagues, and we do find that of those two tests, the sensory test is the most sensitive one that's obtained. It will show a latency of the tibial nerve and the terminal branches as those nerves course through the tarsal tunnel itself. Now, it may be positive in 50 to 90% of patients. I think it's very important to remember this is typically a static. And when you're dealing with more active people, particularly those individuals involved in sports that are presenting with tarsal tunnel symptoms, you have to understand that oftentimes it's a dynamic problem. So a static test like an EMG or nerve conduction study may not fully determine the presence of a tarsal tunnel syndrome if it arises from a dynamic etiology. So much like that dorsiflexion eversion test, a positive test may certainly confirm the diagnosis, but an absent test does not preclude that a tarsal tunnel syndrome is present in your patient. What we found over our years of dealing with tarsal tunnel syndrome patients is there's certainly a broad spectrum for severity. This has been actually well outlined in previous publications. This was a publication by Takakura in 1991, also in JBJS, in which these authors developed a rating scale for the severity of tarsal tunnel syndrome and helping to determine which patients may be best for surgical intervention. So again, a rating scale that I would refer you to. So you have defined your patient with tarsal tunnel syndrome based on these maneuvers and based on close history and physical examination. Now, how do you deal with them? And again, they're a very, very difficult population to deal with. These are patients that may have a number of other comorbidities. Obviously, you always start with non-operative treatment modalities. And the simplest of those non-operative treatment modalities is to utilize an anti-inflammatory medication. So oftentimes you'll initiate your non-operative treatment with a non-steroidal anti-inflammatory medication. You can consider a cortisone injection. If you do a cortisone injection in the tarsal tunnel canal or region, you have to be very, very careful not to enter the nerve itself or the surrounding vascular structures. We will use physical therapy for a number of these patients. I think physical therapy will help with some of the desensitization exercises that can be utilized, as well as with good gastroc stretching instruction and education. We will typically utilize an orthotic device for these patients in the early setting. Again, if we believe that they have some component of a dynamic etiology, we want to reduce the valgus and the stretch across the tibial nerve and its distal branches. So your ideal orthotic device utilized for tarsal tunnel syndrome will be one that includes a medial heel wedge with a good longitudinal arch and typically a fairly shock-absorbing liner on top of a more underlying supportive device. In patients who have a significant amount of acute pain presentation, you can consider mobilization with a cast or a boot, and also a dorsiflexion night splint has been found to be helpful in this patient population. A number of medications have been utilized for non-operative management of tarsal tunnel syndrome. Probably the two most common in our country are Neurontin and Lyrica. Those are the product names for those medications that will help to relieve much of the nerve pain that's associated with tarsal tunnel syndrome. Topical compounds can also be considered. They're becoming increasingly popular because they're directed to the site of discomfort and inflammation. These topical compounds can include a number of anti-inflammatories. They can also include gabapentin along with ketamine to reduce some of the pain perspective. Acupuncture has also been used as a trial and may be effective in some of your patients presenting with tarsal tunnel syndrome. And what about surgery? Well, your indication should be quite narrow. Again, this is a difficult patient population and one difficult to get a good surgical result from, so you want to pick your patients well. In general, the patients presenting with chronic classic pain symptoms that have failed to improve with a non-operative treatment course that usually runs 6 to 12 months can be considered for surgery. Other patients that can be considered for operative intervention are those with progressive symptoms, a mass lesion as recognized either clinically or through MRI, those with positive nerve conduction studies, and also a unilateral presentation. The last is a relative indication, being unilateral, but again, studies have found that patients who have a unilateral presentation do better than those who present with bilateral symptoms. Contraindications for surgical intervention of tarsal tunnel syndrome would certainly include any patient who has a history of chronic regional pain syndrome or this so-called reflex sympathetic dystrophy. You also want to avoid those patients that have a history of polyneuritis, and as I mentioned, those who present with bilateral symptoms. They, again, tend to do worse with surgical intervention. And lastly, I think you should avoid anybody who has an inconsistent exam with normal studies. So if you have a very vague presentation of tarsal tunnel syndrome, one that you just aren't certain if it's tarsal tunnel syndrome or not, and then on top of that you have a negative MRI and a negative EMG or nerve conduction study, I would beware of operating on that particular patient. Now, when you do surgery, basically you're doing a release of the tarsal tunnel. And there are some general things you should consider as you embark upon such surgery. I think first and foremost, if you're going to do that surgery, you should use loupes for proper visualization. Your incision will be made at the appropriate area of the posterior medial ankle, and it needs to extend the entire length of the anatomic tunnel. When doing the tarsal tunnel decompression of the tibial nerve, you want to avoid a true neurolysis. You want to basically keep the fat content that protects the nerve itself and just release those fascial bands that may be entrapping and compressing the tibial nerve and its distal branches. You need to completely release those fascial bands over both the medial and lateral plantar nerves as they course through the deep fascia of the abductor hallucis muscle. I do think it's important to always consider performing a partial plantar fasciotomy at the same time as the tarsal tunnel release. Again, a number of your patients may have a component of plantar fasciitis in addition to tibial nerve entrapment, and this is a good time to go ahead and manage both of those potential problems. Now, the incision itself is made approximately 1 centimeter posterior to the medium malleolus. That's depicted there in the photo on the upper right. You want to extend that incision to the plantar aspect of the heel pad. Basically, you're reaching the anterior aspect of the heel pad going in an oblique direction. One of the problems I oftentimes see is a patient who may present to me having had a tarsal tunnel release with no improvement in their symptoms, and yet their incision is extending over the course of the posterior tibial tendon or FHL or FDL tendons. The incision you want to make is one that extends to the heel pad as depicted here on the lower photo in the yellow. Again, aim towards the anterior aspect of the heel pad. This is going to be the more effective incision to adequately release the distal branches of the tibial nerve through the fascial layers of the abductor hallucis. Again, it's important to know your anatomy as you embark on this surgery. This is a picture from clinical files, again, of a patient who had a large ganglion in the region of the tarsal tunnel. We've outlined the medium malleolus. The incision will be made approximately 1 centimeter posterior, And again, you need to understand the direction of both the medial plantar and lateral plantar nerves as illustrated in this particular photo. This is from an article by Dr. DiGiovanni and Dr. Gould in 1998, and is a very nice a review of the anatomy of the tarsal tunnel and the structures that are appropriately released with a tarsal tunnel release. Again, you'll see here the association of the plantar fascia with the abductor hiatus muscle and its fascia, along with the nerves and their location as they course through that area of the hindfoot. Going into more detail with some clinical photos, you'll see here a patient of ours, posterior medial ankle, the incisions made over the tarsal tunnel. This is a person who's presenting with a true tarsal tunnel syndrome, so we want to adequately release nearly the entire roof of that anatomic tunnel. So once you release once you incise your skin, you'll see that there's a flexor retinaculum that is just deep to the subcutaneous layers of the ankle, which oftentimes can be quite limited in thickness. You'll find your flexor retinaculum as you puncture through it. You make a small puncture of the flexor retinaculum just posterior to the neurovascular structures. We use an elevator to basically inspect that tunnel to actually make sure there's enough volume to then place our dissecting scissors, our Littler scissors, into the tunnel itself. So you see there on the right we have our curved dissecting scissors. We try to keep the tips of that scissors directed superficially so we do not inadvertently create any injury to the underlying neurovascular structures, particularly to that of the vein. If you do nick a vein, you'll get a significant amount of bleeding, which will hamper your subsequent dissection and decompression. Once our flexor retinaculum is adequately decompressed to the proximal direction, we then extend distally. You'll find the fascia of the abductor hiatus will be quite thick at its more superior border. Many people describe this as being the laciniate ligament. We'll go ahead and we'll release the superficial fascial layers over the abductor hiatus muscle itself. We try to maintain the muscle fibers not only for function but also to diminish the amount of post-operative bleeding and hematoma formation that might otherwise occur if you do divide those fibers. Once we have those muscle fibers defined, we'll then reflect them inferiorly, and then you'll be able to visualize the underlying deep fascia of the abductor hiatus, and that too needs to be fully released. Again, while we are doing this dissection, we're trying to preserve the fat over the nerve branches themselves. Once all fascial bands have been released, you will be able to see that the medial and lateral plantar nerves have been fully decompressed. Again, you can take a freer instrument to make sure that the so-called fibrous arcades that basically cover the separate courses of the medial and plantar nerves has been fully released. If you have a patient that presents with a jogger's type foot or somebody who presents with a more distal symptomatology, you're going to want to go ahead and release the fascial layers down towards the plantar edge of the first metatarsal. If you have somebody who presents with a more classic Baxter's nerve or lateral plantar nerve symptoms, then you need to release the quadratus plantae fascia that underlies the abductor hiatus muscle as well. As I mentioned before, we'll also include a release of the medial third of the plantar fascia when performing a formal decompression of our tarsal tunnel syndrome patients. Now, once you've done an adequate decompression, there has been information about the option of inserting an amniotic tissue to decrease scar formation. This is a reasonable thing to consider. There's been some good recent literature, particularly from the ophthalmology arena, that amniotic tissue can decrease scar formation and may be particularly useful when doing nerve decompression procedures like this. So it's something you might want to consider is the use of amniotic tissue to cover your nerve elements and try to decrease scar formation post-operatively. I also recommend a release of the tourniquet for these patients undergoing tarsal tunnel releases. I think it's important to achieve good hemostasis before the wound is closed. Obviously, if you have a patient that develops a significant amount of hematoma, post-operatively you run the risk of not only having a failed tarsal tunnel release, but also a wound dehiscence. So we will go ahead and recommend the release of the tourniquet to achieve the hemostasis, and then I go ahead and do interrupted nylon sutures to the skin for a tight closure. I recommend avoiding deep sutures. I don't use any kind of vicryl or other subcutaneous suture closure for these patients, as it may create scarring around the nerve and these terminal branches that have been fully decompressed. Because of the risk of wound dehiscence, I do also recommend keeping the sutures in place for approximately 3 weeks post-operative. Our post-operative care of these people typically is an outpatient surgery. We do place them in a splint, a plaster splint, and we institute non-weight bearing for a period of 2 weeks. They then return at that 2-week mark for a wound exam, and we then either place them into a walking cast or a boot. We'll utilize that walking cast or boot for an additional 4 weeks, with most of the patients being full weight bearing by approximately 3 weeks post-operative. Once they are in the boot, we do also begin a desensitization program to the surgical site in hopes of improving their long-term results. We will also consider a variety of medications in the post-operative period to hopefully improve the outcome. Again, this is all anecdotal, but we've had success with high doses of vitamin C. You may also consider utilizing amitriptyline, Elavil, or another tricyclic antidepressant, which can help basically calm the nerve down after one of these surgical decompression procedures have been performed. You may also use Lyrica or Neurontin. We do use Lyrica as our preferred medication post-operative, and usually it's 75 milligrams BID is the dosage that we'll utilize for a period of 3 to 4 weeks post-op, again in an effort to reduce some of the potential hypersensitivity problems that some of these patients may present with. Also, topical compounds can be utilized, as I mentioned previously. Once the wound's healed, if you do have somebody that has ongoing sensitivity in the area of surgery, a number of topical compounds are now available, and again, you have the option to add a 10% ketamine additive to assist with some of the superficial pain that they may experience. In regard to the more active population, we do let them return to activity when symptoms allow, and that's typically about 4 months after the release has been performed. Just like in our preoperative discussion, we do tend to utilize an orthotic device in these patients post-operative. Again, you'd want a device that has a good cushion along with a slight medial post or wedge to diminish the tension on the tarsal tunnel region. We've also surprisingly found that some of the patients are improved with the addition of a full-length turf toe plate, oftentimes a graphite or carbon fiber plate to the entire aspect of the orthotic. Again, this seems to help to limit some of the stretch of the nerve and its terminal branches. A number of complications need to be considered before you embark on the tarsal tunnel release type surgery. Again, you need to discuss with your patients possibility of wound dehiscence, the development of neuroma or neuritis, certainly that of chronic regional pain syndrome or RSD. They can develop scar with the recurrent symptoms of tarsal tunnel syndrome. With the release of the plantar fascia, particularly if it's a more complete release, you may basically induce a progressive pes planus deformity with lateral column pain. And obviously another complication is those patients who present with no improvement in their symptoms or even some worsening. And again, all of those things need to be considered preoperatively and discussed with the patient rather than postoperatively. What about failed surgery? Well, it's something we'd all like to avoid if at all possible. If you do have a patient that returns and they don't feel like they've received any benefit from the surgery, even worse, it's a time of reassurance, and you need to institute a fair amount of time for these surgeries to fully recover, possibly as long as 12 months. During that time of reassurance, you want to institute appropriate desensitization exercises, and again, a cushion orthotic device will oftentimes be beneficial to the patient. Persistent pain with these failed surgeries may require a pain management consultation, one that we'll oftentimes utilize particularly to assist with medication regimens. Biofeedback in these patients with failed tarsal tunnel releases has also been found to be helpful. We have had experience with the use of implantable peripheral nerve stimulators. Again, this is a very complicated procedure and one that is gives you approximately 50 or 60% improvement only, so one that is utilized as a last resort type of procedure. Other procedures that have been described for failed tarsal tunnel is that of neurolysis with wrapping. You can wrap with veins, the so-called vein wrapping procedure, as previously popularized by Dr. John Gould or Lou Schoen. Newer synthetic wrapping materials are also available for these very difficult situations. The results of tarsal tunnel release for tarsal tunnel syndrome remains quite controversial. I refer to the literature, and you can basically find almost any result you want. Some people say they do well, some people say they don't do well. The general feeling was that patients with an obvious space-occupying lesion, as diagnosed either clinically or with MRI, do better in regard to their outcome of tarsal tunnel release. But even this most recently has been refuted. There's been mixed results with varicosities. I personally have tried to avoid patients who present with tarsal tunnel syndrome from varicosities, as I find that the varicosities tend to recur despite surgical decompression and elimination. Poor results have also been found in the post-traumatic population, those who present with idiopathic etiologies or intrinsic etiologies like the diabetes and rheumatoid we talked about before, and certainly those with bilateral presentation. So again, all those patient etiologies probably need to be avoided if at all possible. The last thing is dynamic etiology, and again, if you basically address the functional pathology, you may have a successful result. So if you have somebody that presents with a planovalgus deformity with tarsal tunnel syndrome, that's a patient that will require a medial displacement calcaneal osteotomy, as shown there on the right, in addition to the formal tarsal tunnel release, to gain an adequate and long-lasting result. The literature in regard to tarsal tunnel syndrome is relatively scarce. Certainly a number of these articles can be referred to and all have merit in their own way. One of the ones that I have always referred to is that of Dr. Klekian and his colleagues from Chicago. They described their experience of tarsal tunnel release in 47 patients over a period of approximately 10 years. The average age of the patients was 38, and the average follow-up was 35 months post-operatively. And these are patients who had basically had an average of 16 months of non-operative treatment prior to proceeding with the tarsal tunnel release. Their most common presentation, the most common finding in these patients preoperatively was that of the triad of pain, paresthesia, and numbness. 81% of their patients had an abnormal nerve conduction study and or EMG preoperatively. Post-operatively, 72% had satisfaction, but there was a 30% perioperative complication rate. So again, this is an article published in 1998, which remains one of the classics in regard to tarsal tunnel syndrome with its surgical technique and functional outcome. This was an article that we presented from Charlotte a few years back with Dr. Troy Watson as the lead author. We had 75 patients and 80 heals over a period of 5 years that also had an average of 20 months non-operative treatment. These are patients, though, that presented with tenderness or tenelles over the abductor hiatus muscle. So these were patients that we basically identified or defined as those with distal tarsal tunnel release, more like that patient population as defined by Don Baxter and his Baxter's nerve syndrome. We did do a tarsal tunnel release at the more distal aspect along with a partial plantar fasciotomy on this patient population, and we had an 88 to 91% satisfaction. Both the VAS and SF36 were improved. We did find that a positive preoperative MRI, one that was positive for plantar fasciitis, specifically had no statistical correlation with the outcome itself. So in summary, tarsal tunnel syndrome is indeed a very unique diagnosis, and I think it's one that is probably overdiagnosed for the most part. I believe that true tarsal tunnel syndrome is a rare presentation. There certainly are other variants and those with more distal pathology that are likely much more common. The so-called Baxter's nerve syndrome or that of the jogger's foot, which signify a more distal nerve entrapment, is likely to be much more common in presentation than that of the true tarsal tunnel syndrome arising in the anatomic tunnel itself. Surgery should be reserved as a last resort I do so only after extensive preoperative discussion and after 6 to 12 months of failed non-operative management. What I usually will tell the patients is that 60 to 80% of patients will get 60 to 80% better. And that is for those patients presenting with a unilateral presentation. If you do the surgery, again, remember your anatomy, be careful with your dissection, and avoid an aggressive recovery post-operatively. These patients require a gentle, gradual, and supportive return to their daily life as well as recreational ones. I thank you for your attention. I'm happy to answer any questions somebody may have about the tarsal tunnel syndrome or the surgical release.
Hey, Bob, this is Brian in Heart Talk. Great talk.
Thanks, Brian. I'd like to refer all these patients to you.
Yeah, just, a couple points. I don't know if you know that Chris DiGiovanni and I are doing a study. We're just finishing up the statistics on the lateral calcaneal slides associated with tarsal tunnel syndrome for correction of hindfoot varus deformities. And we're going to present our results at the Specialty Day at Academy this year. And the finding that the only statistically significant finding from our study is that the osteotomies of the calcaneus that are in the middle third of the tuberosity are associated with significantly increased association with nerve injury, severe nerve injury, which we classified as medial calcaneal nerve branch numbness, and then one or both of the plantar nerves being involved. I know you know that Chris had published a study on the MRI study that looks at the volume of the tarsal tunnel as you slide the heel laterally. So we didn't really see much correlation in our study between the amount of the slide and the amount of nerve injury.
But it was location.
Location, it's more location, and we're not really sure why that is. Or both of us tend to do tarsal tunnel releases before we do our big lateral slides, especially if we're doing a mid-tuberosity osteotomy where we know we're going to be sliding at 8 to 10 or more millimeters.
Right.
So I think in those cases, Chris and my feeling is that we will still do the release, and exactly like you described. Cut the flexor retinaculum and then even extend that into the deep fascia of the abductor muscle. So I think it's, again, we don't know if, because of the ones we did in the middle of the tuberosity, the slides, do we do a bigger shift in those patients? Was it a combination of compression from the and a traction injury on the nerve? So probably a lot of these are traction injuries, especially if you do a big shift. But again, we're still not sure how to avoid this.
Right.
Those lateral slides become a pretty common procedure. They're a nice alternative to a subtalar joint fusion in those patients with severe hindfoot varus. But I just want to kind of give you an update on that. We'll get more information at the Academy. But
I'll look forward to listening to that talk. It was Chris's group that just published their article about the tarsal tunnel volume in last month's Foot and Ankle International. Again, just like you said, reiterating that it's the lateral osteotomies and not the medial displacement osteotomies that seem to be the culprit. And again, just like you mentioned, it's those that have the osteotomy enter more anterior, more distal, like you said, in the middle or anterior aspect that seem to be more implicated with the development of tarsal tunnel syndrome. So in the old days, when we just used a simple Dwyer osteotomy in the very posterior tuberosity of calcaneus, we didn't see this phenomena. And now that we're using more of these powerful Italian triplane type of osteotomies, and those that are both closing wedge as well as lateral shifting, they seem to be more implicated. So I'll look forward to hearing that talk.
Yeah, it probably has more to do with traction than compression, because we thought we would see a big difference in the incidence of nerve injury if we did a tarsal tunnel release before we did the shift. But we didn't see as much of a difference as we thought we would. Although in half our patients we did the release after we did the shift, the calcaneus, and that nerve injury rate was actually higher at 43% then they average at 33% without any kind of a release. But when we did the release before we did the shift, then it went down to 22% nerve injury.
Well, certainly a sensitive nerve, that's for sure.
Sure.
There's a couple questions here in the chat box. One that alludes to my mention of an amniotic tissue product and how we're replacing it. There are a couple of different products that are available made from donated amniotic tissue, and again, this comes out of the ophthalmology literature, so I'd refer you to that literature if you want to know more about this. One of the companies that I have done some work with, in full disclosure, is that of Amniox out of Atlanta, and they have now entered the spine market as well as the orthopedic market, but the idea is that you can place this amniotic tissue over areas of exposed tissue to decrease scar formation. So there are studies currently in progress of using it after chylectomies to try to reduce some of the arthrofibrosis and the scar formation that occurs after a chylectomy in order to maintain improved motion, and also around the peroneal tendons after a tendon decompression or tenodesis, and those studies are currently in progress. We have also been utilizing amniotic tissue for nerve decompressions like the tarsal tunnel release over the last 2 years, and basically it comes in different thicknesses, and because of obviously the exposed nerve, I do not suture it into place. I do lay it on top of the nerve. So what you can do is you can take these various size portions of amniotic tissue and you can actually place them over the decompressed tarsal tunnel. You can actually lay it under the intact muscle belly of the abductor hallucis, and it will stay in that general location as you then close the skin over the top. Again, the idea of this is that it's supposed to diminish the amount of scar formation that occurs in your surgical site. So for those of you who ask questions about that amniotic tissue, I would refer you to the literature that's currently being published by those authors associated with Amniox, the company. Brian, I don't know if you've had any experience with the use of amniotic tissue or not.
I have, Bob, and I use it for a couple of chylectomies of the great toe, as you explained, and I guess anecdotally, I mean, 2 or 3 cases are not a series big enough to really come to any conclusions, but it did seem like the patient's swelling was less and the pain was less. I've not used it for a nerve wrap, but I think that's an excellent indication for it, given the anti-inflammatory nature of amniotic tissue. And again, I think the next tarsal tunnel release that I do, for the indications you described, I'm probably going to use that material. Yeah,
our experience has been anecdotal as well, but I've not seen any ill effects from it, so that's been one attractive part of it.
Sure.